very useful. Now, future of TIVA is what? And my take-home message. And what is your opinion after starting a TIVA? So, if you go to the history of TIVA, then TIVA is very older than even inhalation agent. See, our anesthesia just invented in 1846, but TIVA is 350-year-old. Even in 1656, in Oxford, the dog has given the opium. And since then, in 65, 1872, 1905, 1921, the TIVA was practiced by preliminary that way. And in 1936, the landmark year came, and that was a turning point of the TIVA, where the sodium thiopental was invented. And it has changed the intravenous anesthesia practice. See, believe me, at that time, there were no infusion pump, there was no syringe infusion pump, no even TCI pump. So people were giving by syringe only. After that, ketamine was introduced in 1962. Propofol was introduced in 77. Remifentanil came in 1996. Then dexmedetomidine came. Now dexmedetomidine is going very well in our market. Then in 2020, remimazolam came in the market. These are the drugs which we are not fortunate to have in our India, like remifentanil, remimazolam. And again in 2022, China has developed one other molecule like ciprofol. That is a next generation of the propofol. I will give some glimpses at the end of this my lecture about the ciprofol also. So if you see the history timeline of the intravenous anesthesia and TIVA, then 1932 to 2020, and since last 10 years, the TIVA is going like tremendous changes in our practice. So what is the definition of TIVA? There are so myths and misconceptions about this TIVA. See, total intravenous anesthesia in short form, it is called TIVA. So it is a technique of general anesthesia which uses combination of the drugs or single drug given exclusively by the intravenous route. No other route is given by another. No other routes are preferred without the use of inhalation agent like gas anesthesia, including nitrous oxide. But here, oxygen, compressed air, or helium are exception. TIVA is used in the induction period as well as in the maintenance of anesthesia. So TIVA is becoming a popular because since last 2 years we are facing the corona period, and this corona period there are re-emergence of TIVA in COVID time. TIVA is accepted by so many anesthesiologists. Not even I had heard in America also people are now fascinating in Brazil, in Mexico, wherever I had got a chance to give the lectures. Then I see that there are so many people are fascinating about PCI and TCI TIVA. Why TIVA is popular? Because gas gives always side effect in aerosol and droplet form in the corona time. So TIVA has picked up more than this gas. Now, what are the types of TIVA? Here also there are some questions are asked by personally by the so many anesthetists in all over India and in my territory also. Okay, TIVA is only just give IV line, give intravenous drugs and the TIVA is completed. No, not like that. TIVA is with endotracheal tube, without endotracheal tube, maybe with supraglottic airway, without supraglottic airway, maybe with nasal airway or without oral airway. You can have everything in your airway instruments with TIVA, and without these instruments, airway instruments also you can practice TIVA. So what are the TIVA indications? Almost in all anesthetized patients in any environment, almost in all surgical procedures, any airway procedures. I'm working in the ENT setups and I always give my TIVA in all like MLS, tonsils and mastoids and everything. Patients having a post-operative nausea and vomiting risk like female patients in their 20s, 30s or 40s, they are the most suitable candidate to give TIVA. In daycare surgery, suppose like NORA situation in non-operative locations where inhalation anesthetics are giving difficult. Like you don't have any anesthesia trolley or you don't have any fascinating working station. So you can practice in TIVA. Even I can give you TIVA in any setup like office procedure, like gastroscopy, CT, MRI, any type of. You must have any suction machines and oxygens and some basic emergency drugs. Even trainee teaching. We started a workshops in TIVA TCI since last 6 months. And again, the second workshop is coming in the Rajkot. And these workshops we are giving after 15 days. Even malignant hyperthermia susceptible patients also we are giving this Suppose if family history of the malignant hyperthermia, then this TIVA is more suitable. In remote location, neurosurgery and neuromonitoring are coming in a big way in the TIVA. Neuro TIVA is now preferred by any neuroanesthetist in the world. Even patient choice. Even I have in my surgery also, I had options to give two types of anesthesia, but I have chosen only TIVA anesthesia. So what are the advantage? Except for a slight prick in the arm, the patient is unaware of having anesthesia. The basic requirement to start TIVA anesthesia is just you have to take the vein flown with, means puncture the vein. Then nothing. Patients are sleeping when they are wake up. They don't have any pain. No mask over the face. Very good for the pediatric patient. No sudden concentration of gas or vapor. No risk of malignant hyperthermia. Very low incidence of post-operative delirium. This is my personal experience for good eras after TIVA. My all patients, even laparoscopic surgery, Euro anesthesia, even my another ENT surgeries or daycare surgery, patients are within 2-3 hours, they are out of the anesthesia and they can take the fluid also. Less chances of emergence phenomena because you are combining the drugs, so many good drugs in your practice. Patient's body have a better operating condition for the surgeons. There should be no smell of volatile agent at all in the room, and the patient is usually most grateful to not having had his system saturated with his such a drug. Like you must be aware of that. After some inhalation agent, we should have some scavenging system. We do not have any. See, all theater does not require, and almost 98% of the theater in all over India, they are not equipped with the scavenging system also. So TIVA in that part very useful. Better preservation of the cerebral auto-regulation. It reduces the stress response of the both, even anesthetist, surgeons and patient himself. Patient wakes up as it is from natural sleep. Because we have now a very good intravenous agents. Less PONV, I told you. Okay, there are so many drugs like Dexona, then the ondansetron we are using in this TIVA. So they give very good results. Less operating room pollutions because we are not using in here inhalation agent, nitrous oxide, etc. So almost in all organ, all systems are using beneficial with the TIVA. Like central nervous system, the most beneficial in the system is central nervous system, neuro TIVA, because when I was operated for the spine surgery, they had a nerve signal mapping in my compressing the nerves. At that time, I was not even given any relaxants. So at that time, it was so neuro anesthesia and neuro TIVA is very much beneficial in immune system. Cardiovascular system, even Kalpana is giving TIVA in her practice. In all, even bypass surgery with this TIVA. Post-operative pain, older patients, geriatric patients are having a very vast benefits of this TIVA. Oncology surgery, gastrointestinal system, renal system, almost all systems are benefited with the TIVA. But coin has a two sides. So some disadvantage of the TIVA is also there. But they are not major concerns. Pain on injections. I have told you that before taking TIVA anesthesia, you have to prick the vein. So that is the only things. And sometimes in pediatric patient, it was not accepted. Once you give the injection, then it is irreversible. Disposable may be costly, but I don't think this is a major disadvantage because now all over we suppose vaporizers or syringe infusions, pumps, and these are all these now within our expense limits. Incidence of awareness, if not given properly, you must understand that you should use some monitors also for giving TIVA. Otherwise, you should learn art of the technique of giving TCI TIVA or TIVA. Undetected errors in delivery system, not having another apparatus to carry on the TIVA. Plastic waste, possibility of the not finding the vein. Sometimes in obese patients or very shock patients, you cannot find the vein. Shallow respirations, risk of bacterial contaminations. If you are combining some drugs of TIVA, questions in prolonged procedures or obese patient. This is also one of the not great disadvantage, but I had given TIVA in my 7 to 8 hour surgery continuously in my some urological long procedure. Difficulty in knowing the blood concentration. So consider that TIVA completes the anesthesia cycle. See, in our residency, we learned that okay, what is the components of the anesthesia? That is hypnosis, sympatholysis, amnesia, hemodynamic stability, and immobility, and neuromuscular blockade. All this can be done by the TIVA. Any drug you take, TIVA will complete this anesthesia cycle. Now, coming to the TIVA drugs, which are the drugs which we are using in TIVA? So majority of the drugs used for TIVA, including benzodiazepine, narcotics, propofol, ketamine, etomidate, dexmedetomidine, muscle relaxants, and other adjuvant drugs are also easily available in almost all the operation theaters, even in NORA situation, outside OT. Suppose you have office procedure, and if you have 10, 15 drugs, then also you can give TIVA. So all these drugs can be given by any subset of the population from pediatric to geriatric patient in easily titrable doses. So that is the beauty of TIVA. We can give from pediatric to geriatric patients. And since last 175 years, more than 66 drugs are invented in our armamentarium. And out of this, till date, 20 to 25 drugs are obsolete and 45 drugs we are using. And out of this 45 drugs, now almost 30 drugs are used in TIVA. So this is the beauty of TIVA. We have only 5 or 6 inhalation agents, and just now only 1 inhalation agents are accepted in all over world. But in TIVA, we have a ample opportunity and liberty to use any drugs in our armamentarium. So what is ideal TIVA drug? It has a rapid onset of action, rapid and predictable recovery, potent and lipid soluble. Here it is also watery soluble to minimize toxicity associated with the solvent, stable in any solution, chemically compatible with other drugs. No perivascular sloughing or extravasate, not absorbed by the plastics, does not promote bacterial growth. It must be devoid of adverse side effects, and it should have a low cost. Most important, it can be mixed with either IV anesthetic agent and solution without any complication. In our Indian circumstances, we are not blessed with use by TCI TIVA, means TCI pumps with all the anesthetics. Hardly 1 or 2% of the anesthetics in all over India using must be TCI TIVA. So I promote TIVA in our practical setup also. So it can be mixed by the other solution and other drugs also. So what are the TIVA drugs toolbox in our OT? Dexamethasone, all benzodiazepines, beta blockers, all muscle relaxant, magnesium sulfate, propofol, ketamine, dexmedetomidine, opioids, lidocaine, clonidine, diclofenac and paracetamol. In all my theater, all these drugs are available with me. So I can have a so much liberty to use, but I have modified my own technique of giving TCI TIVA and TIVA in my setup. So I will go in some of the details of IV anesthetic drugs one by one, because this is a DNB clinical meeting. So you must learn something about the basic pharmacology of this anesthetic drug. First is propofol. Propofol is the most popular and most widely used anesthetic agent in induction as well as in maintenance in our TIVA. So it is a prime drug in all TIVA. It can be combined with any drugs. Initially, TIVA dose is 2 to 2.5 milligram per kilogram if you are giving as a bolus and use alone. In any TIVA mixtures, we can combine propofol either with the dexmedetomidine, either with the ketamine, or either with the other agent like fentanyl, remifentanil as a 1 milligram per kilogram. In infusion, we are giving 6 milligram per kilogram per hour for maintenance. And co-administration of the propofol, remifentanil is the TCI standard in highly effective and constitutes ideal total IV anesthesia. Those who are using TCI TIVA, they must be combining all over part of the TCI TIVA practice, this remifentanil pump and propofol pump. But unfortunate part, in TCI TIVA, in India, remifentanil is not available. So people have to alter the techniques of giving TIVA in that practice. And on the right side, some TIVA doses and TCI doses are written on the propofol. So for sedation, light pain, laryngeal mass, moderate pain, surgical anesthesia to deep anesthesia, these are the doses we are giving in infusion dose and target control. So this is propofol infographics. I have based in very details. You can have after that this clinical meeting from the Kalpana only. My second drug is ketamine. Ketamine I called is a brahmastra for the anesthesiologists in TY. You must be knowing that in Mahabharat, the last weapon was the ketamine. Now ketamine, I will tell that one survey was done just 4 years back by the one of the very prominent group in the Facebook, that which is the most popular drug since last 50 years in anesthesiologist across the anesthesiologists in anesthesia. Then ketamine was around 49% of the weightage. Even propofol has even far behind, only 34%. So it is a NMDA antagonist, key role and main drugs in TIVA. One of my most favorite drug, based analgesic, amnesic, and opioid sparing effect. Dose less than 0.5 milligram reduce the postoperative analgesia, and especially seen opioid tolerant patients. It has an anti-hyperalgesic and anti-tolerance effect. Now you know ketamine is used as an antipsychotic drug. If you have a latest knowledge about the ketamine, then in America, more than 100 ketamine clinics are developed to have an antipsychotic effect. And in our this opioid narcotics, now ketamine after see hyperalgesia means if you withdraw the narcotics in the from the treatment part or post-operative pain relief, then patient sudden gets very excruciating pain in this body. And for that pain, because of the withdrawal the narcotics, the only drugs which are very useful is only ketamine. So only intravenous anesthetic agent with hypnotic, and I told you it can be mixed with the all types of the anesthetic and narcotic agents in single syringe. The beauty part of this ketamine is that ketamine is the only drug in the pharmacologic book which can be given by any route. You tell me any route and it can be given. So that is the beauty of. And ketamine can be mixed with the midazolam, propofol, dexmedetomidine, one of the established drugs for the TIVA mixtures. So this is the ketamine infographics. Now it is a scheduled drug. Without prescription, you cannot get in India. My third drug is as an induction agent is dexmedetomidine. This is an alpha-2 agonist. Dexmedetomidine has a, see, I call dexmedetomidine as the most ideal anesthetic agent in my weapon. So dexmedetomidine has a hypnotic, sedative, analgesic property and is estimated to be 7 to 10 times more potent than clonidine. The difference between dexmedetomidine and ketamine is that both have got an anesthetic agent, both are analgesic agent, but the hypnosis is more potent in dexmedetomidine rather than ketamine. So if you consider the combination of these two drugs, dexmedetomidine and ketamine, if you are combining these two drugs, then you have almost everything, whatever you want in anesthesia. And this Dexket combination is very popular, becoming a in pediatric TI now in all over. And more than thousands of articles are now since last 4 or 5 years in our PubMed about Dexket induction. So most ideal anesthetic agent, dexmedetomidine, it has got an opioid sparing effect also. Patients sedated but arousable, alert, and respond without uncomfortable. I want to tell one very good story about this dexmedetomidine. Since last 10 years, I am using dexmedetomidine in my practice. Every day, 5-6 ampoules I am using it, almost even intrathecally, local anesthesia, blocks, and everything about the IV agent. People are asking me in all over from my territory that dexmedetomidine you're not using because of the bradycardia, severe bradycardia and severe hypotension. Then my question is only that, why you are not using? Then some anesthetics are coming that sometimes in this due to severe bradycardia patient may die on table. Then I am challenging to that anesthetist. You show me any article in the armamentarium of the anesthesia journals all over the world that patients are died because of the dexmedetomidine of single dose, not a single article. You can have 40 or 42 pulse rate in, but here if you see that this dexmedetomidine gives a physiological sleep, conscious sedation. See, whenever we are sleeping in midnight, that time, if you consider your pulse measurement, then it is around 40, 45. So that is it works on the local cellular centers in the brain. So conscious sedation is a natural sleep. Patient are sedated. You can arouse him. Again, it goes on the sleep. So this drug is becoming very widely popular in all over part in all anesthesia. So my request is start using dexmedetomidine in your practice. The dose range is 0.5 to 1 microgram per kilogram according to patient status and surgery needs. The only thing is you start very slowly for initial period. And if you are using as a maintenance infusion, then you can give from 0.6 to zero point 0.7 microgram per kilogram hour in titrated. In pediatric TB, I told you Dexcat is becoming very popular and it is preferred in all NORA situation in a pediatric patient. So this is dexmedetomidine. Even dexmedetomidine is also with ketamine is coming as a this nasal drops, nasal aerosols, oral solutions, and everything. Here, I have developed a one ice cubes which is given for the STIVA. Suppose patient is less than 10 years and he is not accepting any prick IV line or something like that. What are the novel premedications to sedate the patients? I had combined midazolam, ketamine, ondansetron, and atropine, and I formed from these ice cubes, and I'm giving that ice cubes 1 hour prior to my anesthesia induction agent. And these patients are sedated very nicely within 1 hour oral. I'm giving oral. So hardly 10-15% of the bioavailability is there from the oral part, and patients are telling that I am getting sleeps, and we can separate that pediatric patient from their parents, and we can take the vein also. So that is a beautiful mocha ice cube I had developed. Those who are not using dexmedetomidine, I have developed one poem. What dexmedetomidine says to anesthetists if they are not using. I am dexmedetomidine. My pet name is Dex. I am your complete friend to play with you in all games like IV, IM, oral, spinal, or nasal. But my favorite game is intravenous with all stages: sedation, hypnosis, analgesia, anesthesia. I love to play with small babies to old age player, but during playing with me, be careful. I am very delicate and fall down with the weak players. I can also play in indoor stadium like ICU patients, most beneficial in the as a sedation continuously for 48 hours. You cannot give dexmedetomidine induction or sedation more than 2 days. I'm always available to play with you and allowed me to play with others. Let us play and enjoy with me. Don't neglect me though I am new player. See, some of the anesthetics are well worth with the propofol, but they don't shift them to dexmedetomidine. So my request is you also start your using some part of the dexmedetomidine in your practice in TIVA also. Another drug is titomidate. It is a cardiostable drug, and I reserve for my cardiac patient for non-cardiac surgery, or in some of the patients where I find that there is a very much fluctuation in the cardiac parameters. So excellent cardiostable drug used mainly in hemodynamically compromised patients as a TIVA induction. The dose range is from 0.1 to 0.4 milligram in ICU, TIVA, and every geriatric patient you give very less dose. This is titomidate infographics. Now opioids. The second group of the drugs in TIVA is opioids. That is fentanyl, remifentanil. Remifentanil is now coming as outdated. It is not used in some of the countries in all over world. But if you are using, then bolus is 3 microgram per kilogram for 30 seconds, followed by 2 microgram per kilogram per hour for 30 minutes, then 1.5 milligram per kilogram per hour. Then maintenance is 1 microgram per kilogram. Remifentanil. Remifentanil I never used in my practice because it is not available. It is available as a 1 milligram, 2 milligram, and 5 milligram vial. Initial dose is 1 microgram per. It is a very short acting drug. And in TIVA maintenance, we give 0.25 to 0.5 microgram per kilogram per minute IV TCI. Post-operative period, this is 0.025 to 0.2 microgram. This is fentanyl infographics. This is remifentanil infographics. Now, one of the drug was developed by the Japan Paeon company, that is ramimezolam. This ramimezolam is available now all over the world except the Asian countries. In Japan, it is called as a this Paeon. This name is Anirem. In USA, it is called as a Bifeo. In China, it is called as a Roima, and in European countries, it is called as a Aptimida. The beauty part of this that it is a combination of the narcotics plus benzodiazepine. It has got a benzodiazepine property as well as opioid property. It is a very good drug, and I consider this drug will change the practice of the anesthesia in coming years. Some of the adjuvant drugs are also I am using. One is midazolam. Now midazolam is not used by so many anesthetists. It is now only reserved drug. The dose is 0.5 milligram per kilogram. Co-administration of Midazolam in TIVA reduces the induction dose and the total dose of any anesthesia, other anesthesia drug. But consider don't give more than 10 milligram in a one sitting. This is midazolam infographics. Another drug, magnesium sulfate. One of the most favorite drug in my practice. I called it is a old wine in a new bottle. It's a magic drug. Also, I'm calling as an intravenous oxygen. It is an analgesic adjuvant useful in patient receiving total intravenous anesthesia. Reduces all the agents like propofol, dex, atracurium in postoperative narcotic consumption. Available as a 2 ml ampule in 500 milligram. It costs only 10 rupees. It improves the quality of the postoperative analgesia during TIVA. Very cost effective. The dose is around 30 to 50 milligram and maintenance is 10 milligram per kilogram per hour. So what is its effect? It is a antihypertensive, bronchodilator, antiarrhythmic, analgesic, anti-seizures, anti-shivering, anesthetic adjuvant, and antacids and mild sedatives. So what else? Almost 32 clinical effects of MgSO4 during anesthesia. I'm not going to read all these effects. So most versatile drug in the anesthesiologist armamentarium. And I personally tell you, okay, before each, even in any pediatric patient more than 5 years, you can give according to this magnesium sulfate. Magnesium sulfate I am using in minor patients to major patients to even low regional anesthesia everywhere. So very versatile drug, old wine in a new bottle, and I called it is an intravenous oxygen. Another is dexamethasone. This dexamethasone is a universal friend of the anesthesiologist. Why? It is used widely in a TIVA as an adjuvant. It is an anti-inflammatory, prevents and treats postoperative nausea and vomiting. Here I would like to quote some of the article comparison. This dexamethasone is as equal as this ondansetron in that giving postoperative nausea and vomiting. It provides a sense of well-being. One dose you give 6 to 8 milligram, then you just see the beauty part of this postoperative well-being of the patients. Good eras, good quality of recovery in early discharge in patient from TIVA anesthesia. Single prophylactic dose of dexamethasone, it can be given irrespective of the age, sex, and ASA disease. This Dexona, if you give one dose, then it increases only 12 to 24 milligram of the sugar, even in diabetic patients. So I'm also giving in diabetic patient because 12 to 24 milligram, even surgical stress or anesthesia stress also increases. So it is antiemetic, anti-nauseatic, anti-inflammatory, analgesic, anti-shivering, increased quality of recovery, and no effect on sepsis or sugar in single dose. Universal friend. Another drug is lidocaine. It is a best companion for the anesthesiologist. You give 1 milligram per kilogram body weight as a pre-medication and you forget about this. Suppose in patient's body, everything is like some machine is there and all the parts are irregular. Then this, like in body, everything is irregular. Then you give one dose of this lidocaine and everything becomes regular. Even it gives analgesic, anti-hyperalgesic, anti-inflammatory. It reduces opioid analgesic consumption, anti-arrhythmic, improve the patient's outcome, and even decrease the aerosol and droplet during extubation. So I am giving in intubations and as well as the time of extubation. It's a magic drug. There are some adjuvants in our practice also in TIVA. Some of them are paracetamol and diclofenac sodium. NSAIDs. Paracetamol now it can be universally given by all the anesthetists and pints are available. Even bulbs are available of 1 ml, 2 ml ampule, 3 ml ampule and 10 ml bulb. But I am using 100 ml this 1 gram pint only. It's a preemptive analgesic. It has got a opioid sparing effect. Loading dose is 30 milligram per kilogram and maximum not to exceed 2 gram. Very innocent drug in TIVA and can be repeated at every 6 to 12 hours interval. Excellent adjuvant in pediatric TIVA. Now Brufen is coming in the market as a intravenous, and in all over USA and Canada, they are using Brufen intravenous anesthesia as a preemptive anesthesia agent. Another drug is diclofenac sodium. It is a time-tested drug, and now we can give intravenous. So powerful NSAIDs in TIVA with analgesia and anti-inflammatory action. Best is given in a single dose of 1.5 milligram per kilogram. Here I have written just aware of that, not 1 milligram per kilogram. It is given as a 1.5 milligram per kilogram. Minimum 1.5 milligram you can give. It can be given to any set of the patient. Use aqueous solution only. Before that, there is a benzyl alcohol solution were available, and that's why it was not given IV. But sometimes you have to be cautious within renal, hepatic, pulmonary, and heart failure patient. Here, I want to again emphasize that whenever you use paracetamol or diclofenac sodium, always give both drugs before surgical incision to inhibit the prostaglandin receptors. Why? Because once you give the skin incision and then after you give diclofenac and paracetamol, then there is a 50% effect only. If you want a 100% effect by inhibiting these receptors, you must give before surgical incision. Sometimes our surgeon says that okay, we will give at the end of the surgery, but don't do that job. You just tell them that I will give before my anesthesia starts. So this is paracetamol. This is diclofenac sodium. Now again, last drug in my practice is esmolol. That is a beta blocker. Very excellent beta blocker in our practice. It gives a opioid sparing effect, and most part it is gives central analgesia because is it a highly beta 1 selective properties. Does not block beta 2 receptor, and this is more likely to cause hypotension and bradycardia. Esmolol can be given safely to even pediatric patients. A very short acting, very beautiful drug. Almost in all laparoscopic surgery, this is my pre-medications. It is widely used in anesthesia. So I called it as an emergency friend. Sometimes you get a hypertension and tachycardia. At that time, you just give at the dose level, then your everything will be come down. Surgeon sometimes says in your head and neck surgery or laparoscopy, sometimes give hypotension, give hypotension. You give or 2 or 3 ml just as a state. Patients are very comfortable. So this is infographics. Now TIVA drug combinations. See, why I'm giving practical updates of this, my topic's name is practical updates and how I practice. Because I told you in my initial slides, TCI TIVA is used only by 1 or 2% of the anesthetists in all over India. So we have to have some of the alternatives how to give an TIVA in our practice, not by TCI pump, but simple infusion or with simple syringe or by some of the IV infusion. So what to understand before mixing any drugs of anesthesia? See, we have learned in our anesthesia residency program about the anesthesia triangle. The concept of the anesthesia triangle works with the hypnosis, analgesia, and relaxation and their interaction. The thing is over. Any medication entering this prism may result in different interaction, pharmaceutical, pharmacokinetics, pharmacodynamics, and thermodynamics. You take any drugs in anesthesia, they work on hypnosis, analgesia, and relaxation only. So the rule is not mix more than 3 drugs for this effect. And this is a beautiful article given in Column Journal of Anesthesia in 2007. Which drugs can be mixed with which drugs? So drug interactions are the cornerstones of the anesthesia triangle, and being aware of those interactions may contribute to safe anesthesia. The prima facie is like, suppose if you are taking propofol, then propofol can be mixed by any drugs. Ketamine you can mix with any drugs. Propofol, thus only be aware of that you should not mix with the muscle relaxant. So this is time tested. And believe me, we have done so many practice of combinations that if you combine dexmedetomidine with ketamine or dexmedetomidine with propofol or whatever, but you have to use within 6 hours that combinations. Even when you are entering your TIVA practice, then how you start with your TIVA. So I have developed one TIVA kingdom. Like if you are going in battle of the anesthesia, then if you are giving TIVA, then here the anesthetist is king or queen. Our prince is propofol. Our commander, there are 2 commanders. One is ketamine and dex. Our other soldiers are magnesium sulfate, oxygen soldier, then esmolol, emergency soldiers. Other commanders like fentanyl, remifentanil is also in our battle. Lidocaine is a magic soldier. Then other soldiers like dexamethasone, midazolam, and other drugs are other soldiers. So how you take all drugs in your battle of TIVA? TIVA, here King will decide. We will decide in pediatric patients, in shock patients, or in NORA patients, or in our maintenance, which drugs will be combined with which drugs, or we can give alone a drug. So here King will decide their military in battle of the TIVA, whom to stand alone or combinations. So here propofol, just now in this era, propofol is the most common warrior and goes in every battle of anesthesia in replacement of the anesthesiologist. So propofol can be given to any subset of the patient, but sometimes prince with one or two supreme commander like ketamine or dex can be combined with the TIVA maintenance. So if the battle is prolonged for some more than 1 hour, 2 hour, 3 hours, you can combine other drugs also. And in pediatric TIVA, pediatric battle, in absence or presence of prince, two supreme commander, like we were using propofol ketamine in that part before. So it was called a ketofol, but now Dexket is coming. Here, yesterday only I did the message from Barry Fratberg. He's a very good friend of mine. I called him as a godfather of opioid-free anesthesia practice in 1990. He has changed the opioid anesthesia practice with the base. He may had given 6,000 patients in cosmetic anesthesia. And he started a ketamine propofol combinations in his practice. Maybe he must be in this my lecture also. Okay, fine. So he's a very good friend of mine, and ketofol was invented by him. So nowadays, hello. So what are the combination? So what are the combination we are doing? One is KPD. KPD is my own baby. I have developed in last 10 years. That is ketamine, propofol, dexmedetomidine in our single syringe technique. Then ketofol, ketodex, dexket, or ketomed. Now people came with the fentanyl propofol or remifentanil propofol. And in South India, people came with the PDF, MDF, or ketomed, like propofol, dex, fentanyl, midazolam, dex, fentanyl, or ketomed. So some of the words about the ketofol, first established in 1990, physically compatible, chemically stable in 1 mixtures. So you just mix with 1 milligram in mixture, and syringe 3 hours. It is stable at room temperature up to 3 hours. No significant change in pH up to 3 hours. No separation, cracking, color change, gas formation, and it is wisely. I think almost all anesthetists have used this combination in their practice. Then came ketodex. Now I'm not combining ketamine with propofol, or I'm giving dexmedetomidine with ketamine. So ketamine 1 milligram, 1 microgram. So you just like ketomed also. Ketomed I was giving in my earlier days of the anesthesia. So you just consider how the dose is going. Only one. You just remember one means figure of one, either 0.1, 1 microgram, or 1 milligram. These are the ways I. Now I come with my own technique, that is KPD, ketamine, propofol, dex. I combine all these three drugs in the mixtures of one syringe. I take 12 ml of syringe, where we can have 13 ml of the solution. In that, I take 1 ml of 100 microgram of the dexmedetomidine, 10 ml of the propofol, and 2 ml of the ketamine. So it is a 100 milligram, 100 microgram, and 100 milligram of ketamine. Combination of all these drugs permits lower dose of each individual agent for TIVA and reducing their adverse hemodynamic and respiratory effect. Used as a bolus, maintenance, and short cases. I gave according to my own anesthesia pre-anesthetic checkup. If suppose it is a less than 30 minutes of surgery, then I give very bolus dose. The advantage is low dose of each agent compared to full dose. All these drugs are mimicking their each other effects. Like propofol is a universal drug, but ketamine causes hypertension and sometimes tachycardia. So it will be reversed by this dexmedetomidine. It causes hypertension and bradycardia. So each other effects are minimized. So it gives less dose of, decrease the dose of individual, stable hemodynamics, decrease airway complications, and rapid recovery. Now I want to tell something about this KPD mixture. I had given from 10 minutes of surgery to even 7 hours of surgery, these combinations, and more than 10,000 patients I have completed with KPD solutions. People came with the propofol fentanyl, combination of propofol fentanyl. Propofol dose reduction is 50%. I don't know how people are using or not. Then RP-TIVA, that is remifentanil propofol, can be mixed in polypropylene syringe and used for 36 hours. Remifentanil concentration up to 50 microgram per. Color and clarity good with pH stable. Here we don't have remifentanil even in our practice, so I don't have any idea how it is used. Very short acting, adequate analgesia, satisfactory hemodynamic and rapid recovery. But in all over other parts of the world, it is most widely used as a TIVA combination and TCI peoples. Coming to the methods of giving TIVA, how we are giving TIVA in our practice. TIVA is given by either with a single drug or with a combination of drugs. Again, I am telling you that I am not against of any even TCI people or simple those who are giving TIVA. All the methods, if you are comfortable with your own comfort zone, then you can start TCI TIVA. You can start TIVA in your practice, but start TIVA. So it can be given with a single drug or with a combination of drug by single syringe technique or mixture of the drugs or with only one drug. Even we can give with the continuous IV infusion through drips by syringe infusion pump. Then target control infusion, very set criteria of the doses. Even people came with the automated drug delivery through the closed loop system. You forget about the drugs, how it is given, just automated drug delivery. It was developed by so many people in the world now. Coming to single syringe TIVA, where some of the short cases in private practice, we have from 10 minutes to 20 minutes of the surgical procedure in our routine practice. Suppose I am doing a 5 case in a day, then almost 1 or 2 cases I am doing that with this type of the single syringe TIVA. No additional investment for TCR closed loop systems or no need of expertising. Single syringe or pump can be used. Only one syringe is used. Like I told you about the KPD mixer. Short procedure can be managed with the intermittent bolus without syringe pump. It can be practiced in low dependent setups and outside even operating room. It can be given as a bolus as well as maintenance also with the single syringe TIVA. Even we are giving manually controlled infusion in our maintenance, like manual dosing of the anesthetic agent during TIVA with fixed infusion rate. I'll come with the dose rate and with syringes or with IV drips. People have developed before TCI Bristol regimen and target was 3 microgram per kilo. This is for the propofol. How it was given? Suppose when TCI machine was not developed just 10 years back, then how it was given? Loading dose is 1 to 1.5 milligram of the propofol. People are going up to 2 milligram or 2.5 milligram also. Then after 10 milligram per kilogram per hour for 10 minutes initially. Then reduce the dose up to 8 milligram per kilogram per hour for next 10 minutes. Then the maintenance for even 1 hour to 6 hours or for the 24 hours. 6 milligram per kilogram per hour thereafter. So it gives the BIS means in bispectral index, it is given up to 45 to 50 reading. The people are asking that, can we dilute propofol in our routine pint? Yes, you can dilute. The question is, can we dilute propofol? Answer is yes. It is compatible it can be diluted with 0.5% glucose, 0.5% NaCl, RL or DNS. Commercially available propofol in concentration is 1%, means 10 milligram per ml. A 20 milligram of 20 ml of bulb is available as a 10 milligram per ml. The fundamental rule is you take 1 ml of propofol and 4 ml of distilled water or whatever the other solutions are there. So dilution is 1 part of propofol and 4 part of the other solution. How I am doing in my practice, I am taking 100 ml of normal saline. I remove 20 ml solution from this infusion. I'm adding 20 ml of 1% propofol and 80 ml of NaCl infusion. So infusion becomes 2 milligram per ml propofol. Maintenance dose, which I have told you about the Bristol regimen. So once the initial bolus dose is given, then I switch over to bolus dose is 6 milligram per kilogram per hour universally. So in 65, suppose 65 kilogram patient is there, then you can finish the infusion within 30 minutes. This concentration level maintains the propofol in the body. And this is a clinically, this FDA approved solutions and this downline I had given the link. And if you go to this link, then there are more than 7,000 studies are there. In market, total intravenous anesthesia sets are available. Now come to the target control infusion. Now I am just promoting target control infusion in our workshops, and we are coming with the so many pumps now. I'll come to next slide. Which are the pumps are available, TCI pump. So what is target control infusion? So many anesthetics are telling that okay, we don't know about the TCI now. So what is TCI? TCI is a simple term. It is a target control infusion control to achieve the preset drug concentration in the plasma or effect side. Here you just differentiate that okay, when you are giving 6 milligram, 8 milligram, 10 milligram, whatever the propofol per kilogram per hour. Here there is a fixed dose regime. Suppose in blood concentration, either you give 3 microgram, nanogram per ml per hour, like at plasma sites or effect sites. So key components are user interface to enter details and target blood concentration, software with the pharmacokinetics and pharmacodynamic model validated to specific drug to control infusion. So for propofol, one TCI pump is validated. For remifentanil is other pump. You cannot use propofol in remifentanil TCI pump. So that is the way vice versa. And there is a communication between the control unit and pump hardware. And computer will decide what it will be the target control. Two types of the TCI-TY infusions are available. Specific drug model. Till 2021, we were having a specific drug model. Like for propofol, one TCI pump is available. For remifentanil, one TCI pump is available. And for other narcotics, other for muscle relaxant, like that. Now people came with the general purpose model. That is a Aliweld model. It was developed by Dr. Aliweld in I think Switzerland. And these are the pumps are available in the market. Acromed Aliweld, BD, LRS PKPD, HP Med Captain from China, and B Brown. These all pumps are specific agent, but general purpose model was developed by 2 or 3 companies in the world. Even China people came with the single serine TCI, double serine TCI, 3 serine TCI. And he's the father of modern TIVA techniques. And he has developed the first deprefuser pump in 1996. We called as a first TCI father. So what are the benefits? Here, if you are using TCI, then more predictable onset of the anesthesia, more predictable offset of the anesthesia, higher stability during maintenance, short time to recovery, low incidence of PON, short time to discharge. Believe me, in this TCI pump, when you close this TCI pump at the end of the surgery, then that pump will tell you that patient will come out totally out of the anesthesia within 10 minutes, 15 minutes, 11 minutes, or 12 minutes. Pump itself will say that it will be there. And economical benefits are the overdose of the propofols are not the, means any drugs are not it. It saves the nursing time, limits the need of the antiemetic therapy, allows the patient an early return of the work. And that is why we are conducting the workshop all over India now to teach the people, anesthetists, how TCI pumps are used now. So these are the specific pumps are available like for propofol, Mars, Schindler, for pediatric perfuser, Kataria, and for remifentanil, specific one for Minto, alfentanil, Maitri, and sufentanil gaps. And this is the general purpose model. See, one TCI pump for all the drugs. Means all the drug software are in one TCI pump. That is, the list are fentanyl, remifentanil, alfentanil, sufentanil, midazolam, ketamine, even dexmedetomidine pump came last year. That is by Dick Pump and Hernywood. That is also available from now. So only one pump you just buy, and any drugs you can switch over in that pump. I have developed my own infusion without TCI. That is a Tushar Choksi infusion. I also called it a TCI infusion. So it is a 3 style. I usually give without TCI KPD infusion after initial dose of the propofol as an induction. I give KPD infusion 0.5, 0.5, and 0.5 per kilogram per hour in 500 ml of RL. If I am using Dex, see, these all 3 infusion, I decide in my patients which infusion will be suitable. In propofol or in some major surgery, I usually start with the KPD infusion. In small surgery like laparoscopic anesthesia or something mastered surgery or URS, I give dexmedetomidine infusion. And in propofol infusion, I may go for the short surgeries like simple 30 minutes or 1 hour surgery. So dexmedetomidine I am giving 500 ml, 0.7 to 1 microgram per kilogram per hour. If propofol infusion given, then I had told you my slides, I give 6 milligram per kilogram per hour and how I am developing. Now coming to last, how it is given closed loop anesthesia delivery system. It is called a ATIVA or CLADS. automated total intravenous anesthesia, closed loop. Here the input is drug delivery. You see the on opposite side is drug, another side is monitors like bispectral index. We using routine monitors like for NIBP, SpO2, pulse. And from that part, suppose if you are giving propofol or any TIVA drug, then the parameters will tell the computer that this drug is lacking and you give more drug in the body. So it causes a vicious cycle. The monitors will tell which drugs to be given, and the monitors and the drugs will give the signals that because of these drugs, the parameter has changed. So that is the way the vicious cycle is going on. Anesthetic, depth monitor, computer, and input of series of syringe pumps are there. And these are the closed loop anesthesia models are available in the theater. You know, very complex one, but we are happy. So what are the benefits of this CLADS? Automatic delivery of the anesthetic drug to the patient. Just you start within 5 minutes and you forget about the patient's body will automatically adjust. Like we learned from the ether anesthesia. Ether will be given by Flecken or by vaporizer, then patient's respiration will give the concentration of the ether, what is to be ether taken inside the body and what is to be given outside the body. It frees the anesthetist from the repetitive task. And sometimes it wants the abnormal rate of the drug delivery. It is very costly affair. But safety of the patients are very much. Now people have developed in Canada, that is eye control RP, that is remifentanil plus propofol, or eye control RPR, that is remifentanil propofol relation. It's a auto robotic TIVA. Robot will decide, like it is a CLADS only. It is FDA approval. It developed by pediatric anesthetist, that is Anser Mino in Vancouver. Now, just for the few words about the how TIVA is given the different groups of the patient. I had taken only 4 groups like pediatric, geriatric, obese, and ASA3. We are giving routinely ASA 1 or 2 patients, but these are the sets of the patient how I am giving. In pediatric, total TIVA can facilitate surgery. You can give TIVA in any sets of the, but as far as rule is that TIVA you avoid in the neonates. Here in TCI, Qatari or Pedfuser pumps are used. Propofol, ketamine, remifentanil, dexmedetomidine are main drugs. And for obese children, use the total body weight. Just remember that. And again, I'm telling Dexcat or Ketodex are main role have in pediatric TIVA. TIVA in geriatric patient compared to inhalation agents in TIVA is more suitable. And see, in my practice, I am very much convinced with the TIVA in geriatric patients rather than to give inhalation agent. Compared with the TIVA, inhalation agents, anesthetics may augment complication related with the reduced blood flow, circulatory depressions, like that. The rule is giving TIVA in geriatric is always give low dose of the drugs, always give slow and always follow. Means go slow and always follow. These are the golden rule for my side to start with the TIVA in geriatric patients. Any drugs, even I'm telling any drugs you are giving, go low, go slow and always slow. Suppose you have considered that magnesium sulfate is to be given 30 milligram per kilogram, 70 kg geriatric patient. So don't give 30 milligram. You start with the half the dose. And even you give very low and always follow that rule. And here, just consider if you avoid hypotension, bradycardia, and other things, then you will the master your tactic. The thing is that multi-para monitoring and oxygen is must in TIVA in geriatric patients, in almost all patients. TIVA in obese patient. It is also an excellent method of administering general anesthesia. I'm very much convinced with my laparoscopic surgery, laparoscopic anesthesia in this obese patient. Recommended dose in obese patient always lower than the non-obese patient. Here always I am giving suxamethinin for intubation. Sometimes people are telling that we are just giving TIVA or propofol and we are putting IGL or intubations like that. But it's not like that. You have to give advisable for that. Suxamethinin. Obese patient always secure the airway to avoid respiratory depression with nasal or oral. Multi-para monitoring oxygen is more. Even risk 3 patients. I'm giving this with all the monitoring and everything. TIVA can be given to seriously ill patients. There are no specific protocol for TIVA in ASA 3 patients, but you can follow your own rule. And multi-para monitoring and oxygen is must during TIVA. Here, the choose the most appropriate TIVA drugs, like whether patient is elderly or young, or whether the patient is obese or non-obese. So my downline statement is that surgical procedures, what we can do under TIVA, you name from OT to outside OT. We have only liberty with this TIVA that we can go for any NORA situation, NORA procedure, any office procedure, any OT procedure, even in ambulance also, if you are prone, even in air ambulance also, if you are prone for giving anesthesia, then you can give. Even in space anesthesia also, people have started TIVA. So from pediatric to geriatric and from any surgical to medical specialty. I had an opportunity to give anesthesia in general physician's hospital to pass the Ryle's tube only. So on the side cot of the patient, I had to give some ketamine propofol and I have means inserted the right tube. So that is the beauty of TIVA. Some of the checklist in the TIVA, all anesthesia drugs, airway equipment, oxygen, multipolar monitor are must before giving TIVA. Ensure no leakage from cannula and patient's IV cannula is always visible during the surgery. Syringes should be labeled with the drug name, date, and concentration. I'm always telling to my all residents and my colleagues that always label the drugs for TIVA, because TIVA is more means go parallel to labeling of the drug. Infusion line should be checked every 15 minutes of during surgery. The infusion set through which TIVA is delivered should have a lever lock, so it cannot be disconnected by some of the misbehavior. And if BCR used, check placement before and after surgical draping. Here also, one of the golden rule is when you are using TIVA or TCI, always use BIS, but bispectral index are not used by all the anesthetists. So other monitors are, we can be well worth with this type of the monitoring. At the end of the case, ensure all tubings IV cannula which had a TIVA drugs by any method are flushed to prevent inadvertent bolus in ward. So what are the monitoring of the TIVA? Believe me, I still consider whatever the up till 200 years before and 200 years after of anesthesia, whatever the monitors are invented or will be going to invent, I will consider myself as the best monitor of in anesthesia because we learn from that part. So we are the most best monitor as the anesthesiologist. We can see loss of response to shaking or shouting, loss of hemodynamic response or limb movement, absence of tachycardia or even bradycardia. I always put my hand on the ring, this radial pulse. And we have a machine monitoring also like multi-para monitor, bispectral index, evoke potential, process EEG monitor, and other monitors. So TIVA has become more popular, practical, and possible due to two main reasons. First, the advanced knowledge of pharmacokinetics and pharmacodynamics property of the drugs such as propofol, ketamine, dexmedetomidine, and newer short-acting opiates, making them suitable for intravenous administration. And second, new concept in pharmacokinetic modeling coupled with the advance in the technology of infusion pumps, which allow the use of algorithms such as syringe infusion pump, target control infusion, and closed loop system. And propofol ramifentanils are dominating in all over TIVA in the world. Now, I don't know, within 1 year, dexmedetomidine will rule over the world with the TCI machine because dexmedetomidine TCI pump was invented in just 2021. Some of the TIVA apps I will suggest you, iTIVA, do TIVA with your smartphone and volumetric pumps in a pharmacokinetic manner. You just put a drug's name and they will calculate the doses and infusions. IV calculator infusion, you put any drug's name, even not even TIVA drugs, any drug. Infusion calculator, easiest and best drug. Anesthesia software. And this is the only drug, this is the only book available in the as a textbook in TIVA, that is by Epsolam. And it is available in the Amazon with the Kindle and paperback. I had a software, means free software, whole book I will share with the Dr. Kalpana and they will give the all the residents too. It is a 28 MB of this book and I recommend all these people, all these residents should start reading this book and then try to go for the TIVA practice. And again, just 6 months back, this Epsolam came with the serious anesthesia app where you have simulation of the anesthesia TIVA practice, TCI TIVA practice. You download serious anesthesia app, name is serious anesthesia, where you can take the case, you can have a drug model in your TCI pump. You can buy these apps also. So this app is also available by Dr. Absalom. So TIVA, in fact, patient friendly, surgeon friendly, anesthesiologist friendly, economically friendly, environmentally friendly, and productivity friendly. Why I call it is environmental friendly? TIVA and green. Like TIVA is not does not require the scavenging system. So I put these words very prominently. So that is the how it is used. TIVA will be a norm in future practice. If you ask to any anesthetists in the world, that TIVA will rule in 2020, 2030 by all these techniques of the anesthesia. So in future, auto TIVA through artificial intelligence with the help of TCI, these are, it is still available, but it will be a rule. Dexmedetomidine TCI just invented in 2020, it was launched. And my dream is that we have a workstation. We are all mounting all the vaporizers in the workstation. So I believe that the company, inventor and scientists will have an idea that all the PCI system will be integrated in the anesthesia workstation. Whatever the general purpose model, it will be integrated in our anesthesia workstation. TIVA will be a norm and new normal, and TIVA will rule in 2030. Now people came with the all-in-one TCI and closed loop anesthesia. This type of the Swiss knife, like one knife has all the instruments, cutting and chopping and everything. So you have this type of the this infusion pumps are also the TCI machine with closed loop anesthesia. And people, those who want to play in between the anesthesia when they are giving TCI pump, then they can have a screen on the TCI pump. You have a joysticks and you can play any game. And this will be the, see in future, the, I was told by the Amedis company, Amedis is like healthcare. This is a metaverse health city, which was just inaugurated in last week only. And they are coming with the metaverse TCI pump in their practice. So this type of the pump is also available in the world. And day-to-day practice, we are all means facing this type of the complex theater in our day-to-day practice, means monitors, wires and gadgets, and so big one alarm is buzzing here, one is here, so we are confused. So what my dream is that I will have only one machine in my practice, that is only one cabinet where only one button is there, one is awake and one is asleep. If I want to put a patient on a general anesthesia, then I just start the switch. It will take over by closed loop anesthesia or by TCI machine or even inhalation agents or whatever way. And if the surgery is over, then I put that button on the awake mode. Then patient will come out. So switch on, switch off anesthesia. Why it is possible? It is not a dream. It will be a reality. I'll tell you. After 10 years, we will be the older people. But believe me, those who are hearing in 2030s or 40s, they will really see that okay, my words will be very much true, because we have a drugs like short acting drugs. We have monitor like that. We can predict out that okay, in patient will come out like TCI machine, general purpose elevated machine, that people will come out within from the anesthesia within 11 minutes, within 12 minutes like that. So this is my own dream. Now some of the newer drugs are also coming in the practice. Remimizolam already came, Sugammadex also came. Now Heptiva, Duzitol is also coming in the market, and Ciprofol. Ciprofol, I will tell some of the words about this. Ciprofol was developed in China just recently in the third phase of the trial, and it is available just for the tasting dose. How it is differ from this propofol? It has got a no pain on the IV line. When you are giving propofol, then there is some pain in the initial period, or patient may complain severe pain. Ciprofol does not have any pain. It is more cardio stable, means hemodynamic stability is good. It is more 10 or even 5 times potent than the propofol. And believe me, ciprofol is very short acting and very short means recovery also. So after propofol, I think that ciprofol may rule over the world, because propofol is ruling the world since last 30 years. So my take home message: total intravenous anesthesia is a viable and safe alternative to the inhalation anesthesia with lots of advantage over the later. TCI pumps and advanced monitor make the administration of TIVA easy and precise. Manual control infusions using regular syringe pump can be used to deliver a pre-calculated dose. The newer intravenous hypnotics and analgesic agents with favorable pharmacokinetic property have made TIVA more popular in wide era of varying clinical scenario and anesthetic demand. Believe me, in last 2 years of Corona, the people have switched over them to TIVA. That is why I have written a very good article in Indian Journal of Anesthesia, re-emergence of the TIVA in COVID time. So think outside the box. You come out from your comfort zone, and for the safe anesthesia, safe surgery, safe patient, even save yourself also. Again, my disclaimer is that I am not against any inhalation agent or any techniques of the anesthesia. So patients who are wants more than gas anesthesia, do not think, start in the footprints of the TIVA, TIVA, TIVA. And I will ask you, what is your opinion of using TIVA or TIVA TCI in your practice? See, people are telling, I won't use TIVA, I can't use TIVA, I want to use TIVA. How do I use TIVA? I will try to use TIVA. I can use TIVA. I will use TIVA. Yes, sometimes I am using the word. Yes, I have used TIVA. So you consider yourself after hearing this lecture, okay, which steps you will reach every day. And I have developed one TIVA Facebook group, TIVA Society of India, and where more than 4,000 members are there. And all the informations regarding the TIVA from all over the world, we are putting. These are the different societies in the world like EuroSIVA, World SIVA, and SIVA.asia. In future, we had a WhatsApp group in our WhatsApp that more than like-minded TIVA TCI lover. And in future, we are coming with the ICIVA, that is the Indian Society of Intravenous Anesthesia, within 6 months. So thank you guys, and I enjoyed the lecture. Thank you, Kalpana, for DNB. If there is any questions, then I am ready to answer.
Yes, I think Dr. Tushar, you gave a very, very comprehensive, a very complete, and a very clear talk about TIVA. And I think that has also stemmed from many questions which I'm seeing coming in the chat box. And before I take each questions, I just wanted you to just go through quickly once the formulation of the ice cubes that you have for the
Okay, okay,
for our residents. If you could just repeat it once.
okay. Now, can I share the slides?
Sure, you are yet on the slide sharing. You
Just
may
a
share
minute,
the
huh?
slide.
Just a minute. Give me 2 to 3 minutes.
Sure.
I can share the few PowerPoint presentation with me because it's a very good for beginners. And now it was gold standard for 12, 15 medical colleges all over India. So that's why I'm very much.
You routinely practice that for all your pediatric cases?
Now for my ENT, I'm practicing
Okay.
definitely.
So this is kind of made in your hospital in each, and it is being kept by you in personal supervision?
Now my people are now developing that.
Okay, okay.
Just a minute.
Since these will have Schedule H drugs, how do you maintain to keep them in control?
Uh, Kalpana, now you know how I have gone further to Mocha issue. Now Mocha is now past history. Now
Okay.
Mocha, I have developed a Doka ice cube. Instead of midazolam, I'm putting dexmedetomidine now. So instead of Mocha, I'm putting dexmedetomidine in my practice now. Just a minute, why it is not said? Can you able to see?
I can see your first introductory slide.
Now, but that may be just a minute. Okay, started Mocha ice cube.
Yes, yes.
Yeah, okay. So this is novel combination for oral pre-medication in pediatric patients. So background is the background is very funny. Whenever some of the things is means forced to do in our practice, then then there is an invention in our life. So in my life, more than 20, 30 inventions I have done in anesthesia routinely. Not anybody has done in all over the world. So this is one of the this. My daughter was just operated for a CLW suture when she was 5 years old. And at that time, you know, our doctors, sons or daughters, they are always think that needle and syringe. If they give injections, there is a fear of the injections. So my daughter was not able to take any injection from my side also. Even for that, I had to just give the like pressure over her, and then I had to give intramuscular ketamine. At that time, I thought that why not to have some of the solution to give some this type of the patient pediatric to put them on the sleep. So background was pre-surgical anxiety in children may result in pre-operative and post-operative complications, and anxiety associated with the operative procedure distressful for the children. And these anxieties are displayed in several ways, like difficulty in separating from parents, difficulty accepting from anesthesia mask, and to assess intravenous line. First of all, intravenous line is very important. So what was my aim? I started, see, at that time, we were giving ketamine orally, midazolam orally, but the effect was not that good. And even when we give something orally to give the pediatric patient, then also they were not accepting. Doctor Saab, mere ko kuch dene aaya hai. Then also they were. So then I thought, and I asked to my pediatrician friend, then they told me that these ice cubes or ice gola is very much popular in pediatric patient. Then one day I thought, why should not develop ice cubes for ketamine ice cubes? But ketamine ice cubes sometimes may give some sort of hallucination to the. So I added a midazolam, I added a ondansetron, and I added a atropine. So I name it is a mocha ice cube. And you know, all these drugs are pharmacologically we can give orally. So initial period in 2004, when I started this giving, I have completed 25 pediatric patient in 1 or 2 months, from 2 to 15 years. And surgical procedure, though I'm a urology anesthetist and ENT anesthesia at that time. So I was giving all this mocha ice cube to tonsillectomy, circumcision, congenital hernia repair, and cervical lymph node with all investigations which are listed in this. And I was giving this ice cube 1 hour prior to my patients. Patients were given mocha ice cube according to age by trained OT staff. Initially, 5-6 patients, I was preparing this ice cube. How I was preparing? I was taking 2 ml midazolam, ondansetron, ketamine, atropine, and these are the dose. And I was mixing all these drugs in a one bottle or one, you know, these pediatric bottles are coming with the dhakkan and in that. And I was adding some of the orange juice also to palatable. And during, suppose if the surgery is at 9 o'clock, then I was giving at 8 o'clock. And believe me, all these drugs are palatable. Patients were strictly instructed to allow sleeping their child after oral ice cube. And out of all these drugs, the oral absorption is only 15 to 16%. Suppose you are giving 100 milligram ketamine orally, then the patient's body will accept only 15 milligram ketamine. And that is very sufficient to give sedation to that patient. So that is the beauty of, and we have done the studies although in pharmacology department of Baroda Medical College also. And these are the textbook dose, and we were giving just near to this dose. So what was happening? After 1 hour, all patients were sedated, separated from their parents without any difficulty. No major side effect. Just now, I'm not giving, but my staff is giving. My staff is preparing this mocha ice cubes and they are giving 1 hour prior to. They put pulse oximeter and they tell their parents that you just put child on a bed only. Not a single patient require intubation or. And during that hour, SpO2 is not going less than 95 because, you know, this is only sedation. So preoperative period is a stressful event for the majority of the pediatric patient undergoing general surgery anesthesia. And for alleviating that part only I had given. And you know what is the beauty part? After 1 hour, the child is telling to parents, Mama, I am getting some sleep. Mere ko neend aa rahi hai. Okay, just sleep it. And our OT staff will go and they will, that mildly sedated child, they will take over to the OT. And believe me, I was able to take at least vein on that patient. And rest of the things are very much favorable for me. Once I take the vein, then everything is possible. So this is the way I was giving. So mocha ice cube is a novel mixture. Now what happens? Okay, I started a doka ice cube. That is a dexamethasone. Doka ice cube is instead of this midazolam, I am using dexmedetomidine, this DOCA, I have completed 100 patients for that, and this is give more good result. Now you won't believe that, Kalpana. These combinations I have started in palliative pain patient, palliative cancer pain patient in the last 3 to 4 means those who are living only for 1 month or 2 months, because in that patient surgical pain means metastatic pain is like 100%. After giving hundreds of ampoules of morphine, everything, patients are not having any pain relief. So just now also, today only my 5 patients are there in the Baroda, where I am giving this Mocha Ice Cube. They themselves prepare, not myself. I give them bulb, midazolam, atropine, everything is available from my prescription, and they prepare. And then they give 2 hours before the lunch or 2 hours after the lunch, like that dinner also. And patient is much painless, and they die peacefully. So in palliative care also, it is becoming very much popular in my area. So that is why I'm giving this. This is the way I'm giving this drug.
So, Dr. Tushar, just to make it clear, you put it in the same the ice cube tray that we make.
Yes,
And
yes.
this whole
That,
solution of 100
yeah, yeah.
ml is put in
But
that.
when you're putting,
Uh,
you must tell your family members also that this. But not we are in the OT theater. All the fridge are there, so probably sister will only operate that theater or means fridge, and that is the way. Till now, there is no bad incidents occurred in my life that patients are died or patients have a major complications, or even in my private patients also in palliative care. Even I am very much benefited with the this palliative care. So much handsome fees are given by these patients also to me for this. And this one incident, and this came in the international one of the peer reviewed journal in the anesthesia also. This article is available on the net also, and believe me, this is taken by so many medical colleges in their um, routine part. And not only from महाराज मेरे से भी आगे निकल गए हैं कैसे, तो they have developed a even they put a sticks on the ice cubes, and they put like lollipop. So this is the these are the modifications they have done.
just recap a bit, I believe there were fentanyl lollipops which had been
Yeah,
taken
yeah,
off the
fentanyl, Zinova,
off the
even lidocaine, lollipop,
they have
that
been
Zinova
taken
was
off the
available.
FDA, no? They had been taken off the FDA approval was not
Yeah,
there.
yeah.
So what do you think is this Mocha Cube FDA approved now? Can we use it
Oh
or
no,
not?
this is, see, this oral ketamine, oral midazolam, oral dexmedetomidine is FDA approved now. So
Okay.
now you can, the combination is may not be like that, but dexmedetomidine ketamine combination is now IV we can give. And again, I am telling you, the absorption is oral absorption. See, if you consider 100% effect in IV, then this is only 15% to 20% maximum. So at least 1/5 dose is going on the body. That is more than sufficient to give just a light sedation to the patient. And that is what we required in pre-medication to this child. And believe me, part, I have taken myself also for that, and I'm very happy.
Okay. Okay, Dr. Tushar, there is a question which
Yes,
says, what is the entropy? What is the, can you give us some comments on entropy for TIVA?
entropy, I have not used it. Very sorry to tell you. This I am using in my practice. So I think
Okay.
if anybody can give answer for entropy, because
Okay.
whatever I am not
I
practicing,
haven't used entropy
I
as
am
yet.
not able to answer that.
Okay, no
From
issue.
reading the book and I can give answer, that is not
No, but no
justifiable for.
practical experience, no
Yeah,
problem.
yeah, yeah. So that is why.
So there is another question which says that can you suggest the name of an app for infusion which you have given? Anything for
Yeah,
the
infusion
Android device?
calculator.
No, Android
Infusion.
device. Is it
Yeah, yeah.
compatible on Android and
All
iOS
these.
platform?
Yeah, these are available in both. The infusion calculator is a very good app.
Okay.
total Total IV infusion calculator. You go to just put a words like infusion calculator, you get a 15-16 app for that. But
Okay.
infusion calculator for all drugs are also available. Even for a specific anesthesia drug is also available. See, itiva, intravenous tiva, that is also one of the good app, where you just put a propofol or dexmedetomidine like that. You will get a, according to age, according to surgery, your doses, TCI tiva doses like that only. So it's like very good. But the thing is that it is sometimes free app, and sometimes if you want to explore everything, then you have to buy this app.
Okay.
And last 1 month before, I had seen this Absalom. He's also good, one of the good friend of mine. So he told me that I have developed a serious anesthesia app, serious anesthesia, where you can practice like a case scenario and simulation. You just put a propofol syringe in that. It is also 1800 rupees of app on the purchase. So this is also a very good app.
Okay.
Yeah.
Another question is, what are your views on TIVA for any of the emergency surgeries?
Absolutely. TIVA is better than, see, suppose I will case a scenario. Suppose you have a trauma patient and patient is in the shock. Patient's BP is only 70 and patient is to be induced. What is the method of inducing? You start ketamine. Ketamine is one of the established drugs. You start another drug. Hello, sorry. You start like that. You see that the response is how you have a TCI machine. You start with the low dose of TCI, like instead of 4 nanogram, start with 1 or 2 patient. You use this machine. So it is not like that we should. Now, Kalpana, what my practice is that I'm not using midazolam, I'm not using nitrous oxide, I'm not using inhalation agent. So my practice is only opioid-free TIVA. So I develop a one term new again. It is not my term, but in literature also it is called a OFTIVA, opioid-free TIVA. So you can have a TIVA in any emergency situations or anything. And one of the things I want to tell all the DNB patients, whenever I am giving anesthesia, I put in my pocket 3 syringes. One is adrenaline, one is ketamine, and one is choline. Whenever there is a problem in your MRI suits, cardiac theaters, or in your situations where you are available but your drugs are not available, these 3 drugs will save you in your life.
Correct.
Absolutely correct. Because if you are not able to intubate that patient, you give scoline. If your patient is complaining of the pain, you can give ketamine. And if diluted adrenaline is there, all these things are diluted or in the bolus dose. But these things, because I learned this in my residency program, that you these 3 syringes, waste of the money, whatever the adrenaline to 1 rupee mein aata hai, ketamine is 10 rupees, then this another drugs are scoline is 35 rupees. But these are the lifesaver drug, I'll tell you.
Yes.
So this is my lesson and take home message.
Yeah, so just to add to this emergency surgery, Dr. Tushar, you mentioned about TIVA with endotracheal tube, TIVA without endotracheal tube.
Yes.
So when you are giving TIVA with endotracheal tube, of course you will be following the fasting guidelines,
Yes,
standard
yes.
fasting guidelines.
Yeah, yeah.
In an emergency situation, when you do not have your patient who's fasting and you are planning to do a plain TIVA without an endotracheal tube, how much of fasting would you like? Like how much of liquids and solids would you like?
My fasting rule is that 1 hour before patient should not have any liquid. That's all. 2 hours before patient should not have any semi-liquids. And at least 4 hours before anesthesia, patient should not have any solid food. That 4-1, I am following 4-1 and 1-4-2. Suppose if abdominal surgery is not there, then my strict instruction to my OT people is that when patient, geriatric patients or pediatric patients are coming for the anesthesia for the planned surgery, you give water 1 hour before to them, even full glass of water. The beauty is that I'm working with gastroenterologists in all the way endoscopies, colonoscopies. It's a routine for me, bread and butter for me. My all patients are 1 hour starving only, because if you're taking water, then it will straight away goes to from stomach to the duodenum, second part of the duodenum, and it will never causes any vomiting, because vomiting starts from the second part of the duodenum. So when water is given, then water will not stay in the stomach and they will pass on the second part of the duodenum. So 1 hour before giving water is and every guideline of the fluid means NBM, they have told us that 1 hour before you can give this. Especially geriatric patient and pediatric patient, following this rule is very important. And no doubt for abdominal surgery, at least 8 hours or something like that is very necessary. Where the intestines are going to touch, then it is very. Even in my neuro patients, my this mastered means ENT anesthesia, 4 hours nil by mouth is okay. Even after surgery also 1-2-4 my rule, to 4-1 and 1-4. That's all. And it's
Of course, there are a lot of congratulatory messages about your talk being really good, and they would love to have a recording of the same and maybe a PDF of your slides that you have just shown. And there's another question which says that when you're doing TCI TIVA, and you have a patient who's morbidly obese with a poor ASA status. She's asking whether would you prefer the Schneider or would you prefer the Marsh model as your TCI preference?
now Kalpana, Snyder and Marsh model is obsolete now. So now Acromed Elevate came. Then so if I'll be having a chance of using that, I will use only Elevate model. But Marsh model is routinely used. Both the pump have see there are certain criteria for this model, this for Snyder, and some criteria for the Marsh model. And we are not blessed with the all type of the syringe TCI pumps are available in our setup. In one corporate hospital, only one pump. But believe me, I'm going to buy this TCI pump of general purpose model. So at that time, that will be beneficial to me. But in that part, suppose obese patients are that, then I will prefer only TIVA infusion in my practice. Tomorrow only I had a tomorrow only I'm doing 6-hour surgery under TIVA for the sex reconstructive surgery for my urologist friend. I'm going to use only for simple syringe infusion pump for TIVA only. That I have planned to induce with the KPD solutions with all the pre-medication, and I put patients on this dexmedetomidine maintenance. That's all. I have done more than 100 patients of SRS, and I'm very happy. All patients are ER1 with around 30 years of 20-30 years of. So that is the way. But tailor-made anesthesia is very important when you're doing some TCI TIVA practice. Sometimes TCI pump is there and I'm not using. And sometimes I'm acute need of some neuro. I'm not doing in neuro anesthesia. I'm not doing any cardiac anesthesia. So in my practice, 90% of the anesthesia practice is without TCI machine. To confess my practice, that's all.
No, but just to finish this question, I think it's the effect side which will be very important.
Yeah, effect side is very important.
In a patient who's obese, because it's the lean body mass that we should take, and you should see the distribution volume. So I think now Marsh has also come out with plasma as well as an effect site, and Snyder also has got an effect site, which tells you the whole patient biometric dynamics, and that what we can feed in and do it that way. The dose, of course, is very lower in that, and it is much safer for older patients, for obese patients, and for ASA class 3 patients. So that is to answer that question of yours. And there's another question which says, how do you manage hypotension while you are doing TIVA? Because all these drugs have got hypotensive side effects.
No, then the person who has asked this question, they have not gone through properly my slides. I have told you, okay, I'm using dexmedetomidine, ketamine combinations. They will mimic their effect. And definitely in induction, I am using KPD mixtures. So there is no hypotension like that. Ketamine is also means not such a like. Suppose, see, we be practical. If there is a hypotension, then you start with giving some sort of this diluted mephenterine in your practice. We in private practice, we have all the liberty to. That is why I told you, okay, you have ample opportunity to use this. If you have a hypertension, then use esmolol in bolus dose like that. But usually with dexmedetomidine infusion, hypotension is not that much when using as a maintenance infusion. Leaves up to 90-100. That is acceptable. See, the rule is that as a cardiac anesthesia, you must be agreed with me. Suppose patient's BP is 140. You can allow that BP 30% of the original BP to your patients as a physiological normal physiological response. So 140 BP, if it comes up to 100 millimeter, then it is allowed. I don't call it as a hypotension.
You generally go by the mean arterial pressures.
Yeah, mean arterial pressure. If it is more than 60, 65, then it is okay.
Another question is there any incidence of propofol infusion syndrome in prolonged surgeries?
No, I have never used more than 4 hours. So
I think the world report is also there that
I have asked so many people, those who are in Qatar, those who are in London, they have never used, they have never faced that problem of propofol infusion syndrome.
Correct. Just one more question, which I thought I would have asked, thought of just touching a topic.
Okay.
When you are using esmolol, you're just giving boluses of esmolol
Yeah.
just for to tide over that tachycardia crisis.
Yeah.
Is it just for your Dexam to take an effect and give you a good rate?
No, no, no.
Because otherwise, esmolol would require an infusion to be started to maintain the therapeutic
No,
levels.
I am never giving by infusion.
Okay.
I have put 10 ml bulb and 10 ml syringe fill up. Whenever it crosses my expectation level of the blood pressure, then I give bolus dose either 2 ml or 4 ml or 6 ml or even 8 ml sometimes. And very slowly, and believe me, it is very short acting as you know, as a cardiac anesthetic. And once it comes, then suppose these are the problems occur when the maintenance or dose of the relaxants are to be given, patient becomes lighter side. At that time, you increase the dose. See, it is a very art of the giving the anesthesia in that part. That is the way you have to learn the TIVA technique.
Correct. I think I would like to invite commentaries from two of our. I mean, many of them are there, but I thought Dr. Daigude, madam, who's a pediatric anesthesiologist who practices pediatric anesthesia, one of our very senior and one of our patrons of DNB Clinical Meeting Series, and also a good teacher with our residents. Madam, if you are there, would you like to comment on anything, or would you like to about pediatric anesthesia and TIVA while Dr. Tushar is here?
Yes, actually, I like the idea of that ice cube, and children will definitely like to have sort of sucking those ice cube. They will be very comfortable. Of course, TIVA is going to be the future, except I also have reservation for neonates. Neonates, I would not go for TIVA technique. But most of the cases, TIVA and local blocks, we are considering. I mean, we are also practicing very frequently, except maybe inhalation agent for just for induction when the children, they come as outpatient and then they are not properly prepared, or we just give midazolam or Dexam intranasal and then take up the patients. Those patients may not be absolutely sleepy. So in those cases, just for a few minutes, inhale anesthetic induction and then go for TIVA and then local blocks. That works very well, and I'm very happy with this technique.
Thank you, madam.
I'm also using Dexam in kids now.
Yes, madam.
More frequently.
Okay. Kalpana, can I ask the madam one question from my side?
Sure, sure.
Madam, what I face in my practice of since last 32 years, putting inhalation face mask over the patient. Initially, I was using for 20 years. But since last 10 to 15 years, I am using that. I'm now never using face mask on the pediatric patient now. Because in my child also, it is very cumbersome and uncomfortable. So they will run away in private practice, or they will beat the anesthetists in the midwhile. So these are the problems we are facing. So we have to develop according to the time, space, and situation. So what I tell, the other alternatives of giving oral medications, like what Mocha is giving, even sometimes another, see this this dexmedetomidine, now this gel is available now in America. So they put a gel over the patient's this buccal mucosa, and then they are giving this nasal drops are available, nasal inhalation. Spray is also available with the midazolam, ketamine, and this. So I prefer more in this part of the anesthesia induction rather than to put on the face mask on the, because see, patients, you don't know that what post-operatively this patient, you ask that patient to come again for the anesthesia, they will never come. It is my own experience with my daughter. Once you put a anesthesia mask, then they will, nahi, mere ko nahi aana hai. Otherwise,
basically counseling of the kids also is very important.
Yeah, very counseling and selection of the patient.
Talk to them in front of the parents, and that counseling and your friendliness towards the patient is very, very important. I think I have seen many of them accept it much better if we
allow the parent presence
and ask them to like a blow balloon and things like that.
Yeah. There are so many methods are available. That is the way, right?
We have with us Dr. Mrs. Lalita Nayak, who's a neuroanesthesiologist and
Good.
has been with us since a long time. Madam, I'd like to have some comments from you.
Yeah. Good morning, Dr. Chopsy. First thing,
Yeah, madam. Thank
wonderful,
you.
wonderful lecture. You are always, I found, like very innovative. You come out with new ideas, very creative thinking, that's what. I was a pediatric anesthetist for 13 years. I wish I had thought of those days. We were giving an intranasal midazolam. And this lollipops were just being introduced. Of course, now it has gone out. I wish I had thought of this ice cube idea. Is really very good, really very good. I also don't use much of inhalation of agent in pediatric for induction.
Madam, I'll tell you, when my spine surgery was done in last September only, at that time, for 48 hours, I was having excruciating pain. And they have described me the Contramal SR tablet. At that time, I take for 1 week. And after this, I was not taking for 1 week. Then on the next day, I got started excruciating backache and even stiffness of the spine. At that time, what happens? The only ice cube were the most comfortable for me, because I was knowing that I have to take. So I have taken myself, and you won't believe it. It is a very good. See, it is like a dream over. Though so much pain relief in our practice means so much nice. See, we are in the like heaven. It is like that.
I must really try. Like which? What about the dose of this ice cubes for adult?
Yeah, adult. See, from I had written in my. If you go to the internet, then Mocha ice cube in our pediatric novel pre-medication you get. But usually from up to 2 to 5, I give 1 ice cube. 5 to 8, 8 to 11, and 11 to 15. Up to 15 years I am giving. But I give now 4 ice cubes in this palliative care patients, all palliative care patients. 1 ice cube in the morning and 1 ice cube in the night.
Yeah, because one of my friend, a very close friend, is the head of pediatrics, from one of the corporate hospitals. He is in the 4th stage of CA with all the musculoskeletal metastasis. Right from clavicle, all ribs, everywhere.
You start ice cube. You start ice cube.
That's what I'm asking, because we are given fentanyl patch and all
this. No, this not work. This is not work. After, see, all this jugglery, patients at the end stage. See, this selection of the patient is only those who are going to survive not more than 4 weeks only.
Yes.
That patients will demand a painless death.
Yes.
That's time it works.
Because other day he called me, he said, I don't want to live with so much pain. I don't know what to do at 3 o'clock. So can I start this ice cube thing?
See, I had completed more than 100 patients. I had given to my nephew who was suffering from osteosarcoma, and he peacefully died after 3 days. Where I started ice cubes. So that is what at the age of 21 he died. And I had given to at my nephew only. So I have not admitted him to any ICU or something else. And at that time, we have completed more than 500 injections of the morphine, fentanyl patch. At that time, buprenorphine patch, Xylocard patch, everything. You name it, and we have completed.
Yes.
Nothing.
Yeah. Then I was very happy to hear this. Today at least I can tell him, and we can start this treatment. Because
you have to write the ketamine on her prescriptions and tell that how should be prepared. But this you go through that paper, then you have everything.
Yeah, I'll definitely. And as a neuroanesthetist, innumerable cases we have done for intraoperative neuro monitoring and TIVA. Otherwise also all tumors, any spine cases. Otherwise also routinely I use TIVA more than inhalation. Minimum I use, inhalation. It's really, and the advantages are too many, for neuro cases. TIVA is. So Dr. Chokshi, thanks a lot for a wonderful, wonderful lecture.
Kalpana, what is your opinion?
Dr. Kalpana, I want to ask you one question. In this Mocha cubes, every time to make it more palatable, do you add an orange squash?
Yeah, not orange. Give simple sugar also. It can be palatable. Okay. You can add sugar also. But this color ice cubes, they are more attractive to the pediatric patients.
Yes.
Orange juice would be a good idea.
Kalpana, what I'm telling you, can you share your experience of TIVA in cardiac patients?
Yeah, in fact, I'm going to take a lecture on the same platform.
Okay, so
but,
thank you.
Yeah, but just to, in brief, I have done at least 20 cases of TIVA. Of course, I've done it with a TCI pump. I have not done it as a manual infusion. Since we don't have remifentanil, I have followed what Dr. Tushar, actually Tushar Choksi had guided me for this as well. So I must thank him for this. So though my propofol does go with the TCI pump, and I generally try to use the Schneider model for the same. And the next infusion which I have has got ketamine and dexmedetomidine mixture in it. And I have done it, out of that I have done 5-6 cases with laryngeal mask airway. The rest of them have been with the endotracheal tube. And I've been able to get good fast tracking results in either of the groups. Of course, in LMA group, my number is not very comparable for TIVA, but I could get more extubation in the LMA group. And the longest that I had a patient who was intubated was at least for 6 hours in the endotracheal tube group. But the LMA group, I could extubate them, most of them on table, and some of them in an hour or two in the intensive care unit. The other thing is that I remember in my armamentarium, I used to always have a beta-lock syringe as a cardiac anesthetist always ready with me, because I do off-pump CABG surgeries which do require a very stable heart rate. But since we've been using dexmedetomidine, I think I've given up using beta-lock in my last of my practices at all. Magnesium, of course, my arrhythmogenic potential has come down. My patients who go generally above 65 years old age, diabetic, because of the handling of the heart, you are activating the J receptors, and they definitely go into atrial fibrillation, post-operative atrial fibrillation. And surprisingly, I have found that my patients are going less into atrial fibrillation with a good magnesium. And of course, I follow the multimodal analgesia. The details of my thing will be coming in shortly when I start taking my TIVA and cardiac surgery, which would be one of the forthcoming lectures. So I think this was a general brief that I could give on TIVA and cardiac surgery. We have Dr. Ketan Parikh as well, yes, and Dr. Kiran Chadda. Both of them are from Breach Candy, and they're both our esteemed teachers in our hospital.
Kalpana, can I ask one last one just before I... Dr. Choksi, you said you are diluting propofol with saline. If you are giving in a pump, either TCI or a regular pump,
you take directly.
Directly.
In that part, you don't have to dilute. So, see, suppose if you have some of the NORA situations there, you can want to give for 1 hour propofol, then almost you have to dilute it. Otherwise, syringe infusion pumps are available, so you directly put propofol in that syringe and you can give it.
There is no, because there is no preservative, bacteremia, and all those things are not there. No, problems.
Not
Thank you.
So, Kalpana, what was my message is that experience is the greatest teacher in our life. Whatever, see, after 32 years of practice and giving 80,000 anesthesia in my practice with all branches, I had given to at skin level to even radiology level to everything. Whatever we have learned and whatever we speak, that is not, I'm telling you, that is a golden rule. But that is most of the, suppose I have completed 10,000 colonoscopies under KPD mixture. Then what else I required personally myself, that any textbook will tell me this is wrong, this is right, this is the way, this is way. I am very comfortable in my comfort zone where my patients are going and coming within 2 hours. And that is the way experience. Your experience is even boosting to me also. Okay, now TIVA is picked up by so many anesthetists. Even neuroanesthesia is also picked up by so many neuroanesthetists as a TIVA. TCI TIVA is a wonderful in our recent invention.
Dr. Kiran, would you like to make any comments, please? Dr. Kiran Chadda.
Excellent lecture. Only thing that I would probably be a little wary of adding anything to propofol as in the infusion. I do not know what would be happening, because this is an oil-based solution. So when you are adding the water-soluble drugs, so my suggestion only would be keep your propofol syringe separate, and other water-soluble agents is what I would probably do. But otherwise, an excellent lecture. Thank you.
I think, Dr. Tushar, you did mention that it also depends upon the hour of surgery and the stability of the infusion. If you have something, how would you like to comment on that?
It is whatever the drugs you mixtures, it is stable up to 6 hours only. Suppose I have prepared a syringe of KPD, then I have to use within 6 hours. That. Otherwise, there is a crackling, there is a gas formation, so that is like that. Dexmedetomidine, ketamine solution, ketamine propofol infusions are time tested now, and suppose ketamine propofol laboratory studies or pharmacological studies are available on the PubMed, where what happens with combining in one syringe after 1 hour, after 2 hours, after 6 hours, and after 24 hours by spectrometry, and they have prove that if you combine and if you use immediately, then there is no problem. As such, practically what my telling is that whenever you give from one line, one IV, consider, just heard the word, whenever you are giving one line for the anesthesia, suppose you are taking one Venflon, and in that you are by one line is going on, and from one you are giving propofol and one you are giving ketamine, then also it is combining in the body. So that principle has to be outside only, because immediately it is going in the body. So there is no problem. I don't think that is a problem, because in America also they put like that. People are always, no, I'm not against anything, but I'm using like that way. See, in private practice, what happens? We have not so much liberty to use so much thing. So we have to have some liberty and experiments, and means not in at the cost of the patient's life, but it.
Are there any more comments or any questions anybody would like to ask? Please unmute yourself.
Ketan Parikh is not. Ketan bhai.
Ketan Parikh he might have been tired after yesterday's CME, so he joined for some time.
He has gone.
Yeah. Any questions?
Kalpana, we have to give the message on Rajkot also. We are conducting TCI TIVA workshop. So anybody wants to join on 15th of this September, 16th of September on Rajkot TCI TIVA workshop, and second workshop is parallel to this, is in Karnataka in some of the that ISA branch. So people can learn on hand training of this TCI pump, and both the companies Acromed and this BD, they are coming, and now we are going to arrange so much workshops in all over India. So most of the people are invited to attend that workshop. So this is the message we want to give.
Okay, since I think what I can do is, Dr. Tushar, I can share the TIVA PDF on this on the platform once again, so then they can look at it, and if convenient, they can join us at Rajkot, or they can even go to the Karnataka Center and learn a little more about TIVA.
Sure.
And I think if there are no more comments, we should call it a happy Sunday. I thank Dr. Tushar so much. All the things that you've given us. Enjoy. Nice. Thank you.
Yeah, excellent, Dr. Tushar Chokshi.
Thank you, madam.
And
thank you.
Yeah,
thank you, sir.
Heartiest congratulations. Congratulations.
Madam, thank you.
Thank you.
Bye-bye.
Thank you, Dr. Chokshi, Dr. Kalpana, Dr. Daigude.
Yes.
Thank you, madam, for joining. Thank all of you all for being with us. Thank you.
Today we missed Alka.
Yes.
Today,
Where is she?
she's busy a bit today. She had excused herself. Thank you.
Thank you, Kalpana.
Yeah.
Bye, madam.
Bye.